Growth hormone agonists. Agonists, does that work for or against? For. Be very careful. It doesn't say antagonist, it says agonist. Make sure you pay attention, okay? So because it's an agonist, it's promoting the release. So growth hormone agonists, they promote the release of growth hormone. The anterior pituitary hormone that is most commonly used pharmacologically is growth hormone. Growth hormone is responsible for linear skeletal growth, the growth of internal organs, protein synthesis, and the stimulation of many other processes that are required for normal growth. Hypopituitarism, you guys need to know this. Hypopituitarism is often seen as growth hormone deficiency before any other signs and symptoms occur. Growth hormone deficiency in children results in short stature. That's what's known as dwarfism. Adults with somatotropin deficiency syndrome, they can have hypopituitarism as a result of a pituitary tumor or trauma, or they could have been treated with growth hormone deficiency as children, and now they have a shutdown of the pituitary production of somatotropin. For table 35.2, just know that for somatotropin, remember that is a growth hormone agonist. It promotes the release of growth hormone, and it's used in treatment of children with growth failure due to a lack of growth hormone or to chronic renal failure.
Make it a little brighter.
That's the brightest. Is that better? Well, now it turns off. So it goes from here, 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 here. That's the brightest.
Okay.
Replacement of growth hormone in patients with growth hormone deficiency. So make sure you know that for somatotropin. Again, somatotropin, is it a growth hormone agonist or antagonist? Okay. Look at box 35.2, growth hormone therapy. Growth hormone can be used to treat growth failure caused by either lack of growth hormone or by renal failure. This is the second time we've seen this. We saw it on the last page, and they're talking about it again. It can also help children with normal growth hormone levels who are just genetically small. So there's nothing wrong with their growth hormone, they're just genetically small. Before the drug's prescribed, the child must undergo screening procedures and specific testing, including x-rays, blood tests, and they must display a willingness to have regular injections. I've seen around 2015, 2016, I saw a lot of, I shouldn't say a lot, but several colleagues be investigated, or even they've gotten arrested because of these hormones. Because you have parents that want their kids to be a basketball star, they want their kids to be, tall or soccer, and they will bring their kids in to get all types of injections. It's very big down here in South Florida. And be careful. So look what it says. They must also be willing to have regular injections. In addition, radiographs, what are radiographs? X-rays. Radiographs of the long bones will be taken to monitor for closure of the, I can't pronounce this word, epiphyses. Remember, that's where the growth in the bone takes place, right? This is a sign that the drug must be stopped. So this is letting us know, guys, once that epiphyseal plate, once that portion of the bone that's the part that grows, once it's closed, that drug has to be stopped. You can't be giving that patient growth hormone if this is closed. This is very important for you to know. I'm going to test you on it.
What happens if it
No clue.
What if you continue give them hormone?
And it's closed? I just told her I have no idea what would happen. I know it's bad. I don't know. Somebody look it up and tell me. You know, Scott? Well, here's the thing with Paget's disease. It's the bones will grow at a very rapid rate, and they fracture easily, but I'm not sure if that will cause Paget's. I can't say for sure. Because the problem with Paget's is that the growth is at an alarmingly rapid rate, and so the bone is not strong. It's growing, but it's not strong, and that's what makes it, and it breaks down easily. That's what makes them at risk for fractures. Maybe, possibly though. All right, insulin therapy and replacement thyroid therapy may be needed depending on the child's response to the drug. Therapeutic indications and actions in clinical practice. The agents that are used purely as a replacement for anterior pituitary hormones are those acting as growth hormone, somatotropin. Remember, again, I keep saying this to you because I'm telling you I'm going to test you on it. Somatotropin promotes the release of what? Growth hormone. You guys didn't drink your coffee this morning? Contraindications and cautions. Obviously, any known allergy. The presence of closed epiphysis. How do I pronounce that word, guys? I can never say it. Epiphysis, or with underlying cranial lesions. Oh, here they give the reasons. Because of the risk of serious, oh, wow. Because of the risk of serious complications. Other contraindications: abdominal surgery, acute illness secondary to complications of open heart surgery. It should be used with caution in anyone that's pregnant or lactating. Adverse effects: development of antibodies to growth hormone and subsequent signs of inflammation and autoimmune type reactions, such as swelling, joint pain, and the endocrine reactions of the hypothyroidism and insulin resistance. Take a look at this box 35.5. When receiving growth hormone, you're going to teach the patient to report any lack of growth as well as signs of glucose intolerance. What are those signs of glucose intolerance? Thirst, hunger, voiding pattern changes. They're going to urinate much more often than they used to. Also report any symptoms of thyroid dysfunction, such as fatigue, thinning hair, slow pulse, puffy skin, intolerance to cold. Those are signs and symptoms of what, guys? Cushing's, right? And you said thyroid disease, absolutely. Hyper or hypo? Hypothyroidism. Okay. Nursing considerations for patients receiving growth hormone agonists. You're going to assess them again for any allergy to growth hormone or binder. You're going to assess for closed epiphyses or underlying cranial lesions, because remember, once that epiphyseal plate has closed, that medication must be stopped. Assess them for any serious infection following open heart surgery, abdominal surgery, pregnancy, or lactation. You're going to assess the height, weight, thyroid function. You're going to do thyroid function tests. Remember the T3, the T4, glucose tolerance test, and growth hormone levels. And the reason for that, remember, we have to have a baseline for the patient. Implementation and rationale. You're going to administer the medication IM or sub-Q. Monitor thyroid function, glucose tolerance, and growth hormone levels periodically. Instruct the family member on the following. The medication has to be refrigerated. It has to be reconstituted. Sterile technique must be used. You're going to teach them to rotate the injection sites, to monitor the injection site. Evaluation. Monitor patient response to the drug. And remember, you have to teach them to report if they stop growing. or they've noticed they stop growing. Monitor for adverse effects such as hypothyroidism, glucose intolerance, nutritional imbalance. All right, we're going to switch gears. Now we're going to talk about growth hormone antagonists. It works against, right? It inhibits the release of growth hormone. Growth hormone antagonists, they inhibit the release of growth hormone. Growth hormone hypersecretion is usually caused by pituitary tumors, and they can occur at any time in life. This is often referred to as hyperpituitarism. If hyperpituitarism occurs before the epiphyseal plates of the long bones fuse, it causes an accelerated linear skeletal growth, which produces the opposite of dwarfism, gigantism, a 7 to 8 feet in height with fairly normal body proportions. In adults, after epiphyseal closure, linear growth is, what's that word? Impossible. Once it's closed, it's not going to grow. It is impossible. Instead, hypersecretion of growth hormones causes enlargement in the peripheral parts of the body, such as the hands, the feet, internal organs, especially the heart. So this is letting us know, as an adult, you're an adult, your epiphyseal plate has closed. So go ahead and take this if you want to, but it's not going to make you get any taller. It's just going to increase those bones in the periphery, right? Acromegaly is the term used to describe the onset of excessive growth hormone secretion that occurs after puberty and epiphyseal plate closure. Therapeutic actions and indications. Do not confuse somatotropin with somatostatin. You guys see the difference? This somatostatin is an inhibitory factor released from the hypothalamus. So somatostatin, is that an agonist or an antagonist of growth hormone? Antagonist, it inhibits. So do not confuse those two terms. It is not used to decrease GH levels, though it does do that effectively. Because it has multiple effects on many secretory systems, it inhibits the release of gastrin, glucagon, and insulin, and the short duration of action, it's not desirable as a therapeutic agent. This is important for you guys to know about it inhibiting the release of gastrin, because it does cause lots of GI issues. Page 585. Bromocryptine? Bromocriptine should not be used during pregnancy or lactation. Growth hormone antagonists are contraindicated in the presence of any known allergy to the drug, and obviously they should be used cautiously in the presence of any other endocrine disorder, such as, you got to know these examples, diabetes, that's an endocrine disorder, thyroid dysfunction, adverse effects. Look at these adverse effects. GI complaints such as constipation, diarrhea, flatulence, nausea. GI complaints are not uncommon because of the drug's effect on the GI system. Other less common adverse effects: headaches, sinus bradycardia, and other cardiac arrhythmias, and decreased glucose tolerance. Nursing considerations for patients receiving growth hormone antagonists. You're going to assess them for any allergy to growth hormone antagonist or binder. Other endocrine disturbances, pregnancy, lactation. You're going to get a baseline on your patient. You're going to get their orientation, affect, reflex, blood pressure, vital signs, growth hormone levels, glucose tolerance levels. Monitor thyroid function, glucose tolerance, and growth hormone levels periodically. And again, get a baseline and periodic ultrasound evaluation of the gallbladder if using octreotide or lanreotide, these two medications. Key points. In children, deficiency of growth hormone may be responsible for dwarfism, but in adults, it's associated with SDS. What does our SDS stand for again? I hate when they do that. SDS should be somatotropin something. Anyone? SDS? All right, you'll find it in the book. Oh, what page?
Oh, here it is. Adults with somatotropin deficiency syndrome.
Thank you, somatotropin deficiency syndrome. You guys know I hate Google. Don't ever Google anything. Google is not for nursing students. All right. Drugs, did I cover drugs affecting pituitary? Did I do that part? Okay, so let's keep going. Drugs affecting the posterior pituitary hormones. That should be easy for you guys to remember because remember, there are only two, right? Two in the back. The posterior pituitary stores only two hormones produced in the hypothalamus. That's your anti-diuretic hormone, your ADH, also known as vasopressin. You have to recognize both. And oxytocin. Oxytocin stimulates milk ejection or let down in lactating women. In pharmacologic doses, it can be used to initiate or improve uterine contractions in labor. You guys are going to learn all about oxytocin next semester when you go into OB. Fun times. The posterior pituitary disorders that are seen clinically involve ADH, anti-diuretic hormone release, and includes diabetes insipidus, which results from insufficient secretion of ADH. Let me stop right there because I gotta make sure you guys understand this. I'll read this in a second, but understand this. ADH, anti-diuretic hormone, it makes you hold on to your fluids. Fluids that normally would have been released through the kidneys and you urinate, you're holding on to it, okay? Diabetes insipidus. Diabetes insipidus. Did I talk to you guys about Oprah last week? Okay, so you guys remember that. When you think of diabetes insipidus, you're thinking about Oprah. Everybody gets urine. You're letting everything go. You're releasing all of your urine, but that urine, is it dilute or is it concentrated? Dilute. What's concentrated?
The serum.
Your serum, the blood. Yes, because the sodium, the glucose, everything that would have been coming out in the urine stays in the blood. Okay, good. I talked to you guys about that. All right, let's move on. Posterior pituitary disorders are seen clinically involve ADH release and include diabetes insipidus, which results from insufficient secretion of anti-diuretic hormone, and SIADH, which is the opposite, guys. SIADH is when the patient's holding on to all their fluids. And in SIADH, even though they're holding on to all of their fluids, the little bit of fluid that they do release, is it going to be dilute or concentrated? Concentrated. What's dilute? The blood, right? Because all the solutes have gone out into the urine and it left the bloodstream. So that's very important for you guys to know. If you guys can understand those two biggest differences between diabetes insipidus and SIADH, is going to make your life so much easier for this upcoming test and med-surg. All right, diabetes insipidus, it's characterized by the production of a large amount of dilute urine containing no glucose. That urine is dilute because the solutes are in the blood. The blood becomes concentrated and blood glucose levels are higher than normal. And the patient presents with polyuria, lots of urine, polydipsia, lots of thirst, and dehydration. With this rare metabolic disorder, patients produce large quantities of, again, guys, dilute urine and are constantly thirsty. I'd be thirsty too if I was getting rid of all my fluids. Plus, remember, they're getting rid of all their fluids, but the sodium and the glucose and all those solutes are staying in the bloodstream. Diabetes insipidus is caused by a deficiency in the amount of posterior pituitary antidiuretic hormone, and that can result from pituitary disease or injury, such as head trauma, surgery, or tumor. SIADH, syndrome of inappropriate antidiuretic hormone. That's when they're holding on to all their fluids. SIADH presents with fluid retention, dilution of the blood, and all of the blood elements, and serious issues with water balance and fluid volume. That is the opposite of your diabetes insipidus. This disorder is now treated with drugs that block the ADH or vasopressin receptors, so water is no longer retained and urine is produced, helping to restore water balance. And that's important because remember, our priority patients are always going to be, issues that fall under physiological integrity, and fluid and electrolytes, doesn't it fall under physiological integrity? Absolutely. Antidiuretic hormone itself is never used as therapy for diabetes insipidus. Instead, synthetic preparations of ADH, which are pure, have fewer adverse effects, and that's what's used. Only one ADH preparation is currently available, and that's your desmopressin. So let's talk about desmopressin, the therapeutic action and indication. ADH is released in response to increased plasma osmolarity or decrease in blood volume. Let's talk about that because you guys got to understand when you see that word osmolarity. I want you to think of concentration, thickness, heaviness, okay? So the ADH is released in response to an increase in the blood thickness, concentration. So that makes sense. If that blood is too concentrated and too thick, and your body's trying to help you no matter what, don't you think your body's going to try to dilute all of that concentration so you hold on to your fluids? It makes sense. It produces antidiuretic activity in the kidneys. These activities reduce the plasma osmolarity. It reduces that plasma concentration, that plasma thickness, right? And it increases blood volume, because at the end of the day, yes, it's decreasing that thickness, but you're holding on to fluids. So it's going to increase the volume. Does that make sense? I'm going somewhere with this, guys. Are you guys following me? Okay. With increased blood volume, with more fluid pushing against the vascular space, what's going to be a concern? Blood pressure. Blood pressure too high or too low? High. Okay. All right. The vasopressin blockers cause a loss of water through urine and therefore increase in serum sodium levels as the water levels decrease. Contraindications and cautions. Anyone with known allergy to the drug, severe renal dysfunction, because remember where the work's happening in the kidneys. Vascular disease. Why? Look, because of its effects on the vascular smooth muscle. Remember that vascular smooth muscle, isn't it supposed to expand for that extra volume? Absolutely. And as the volume goes low, it's supposed to get smaller. Other contraindications and cautions: epilepsy, asthma, hyponatremia, pregnancy. All of these drugs should be stopped during acute illness that might lead to fluid and or electrolyte imbalance, and caution should be used in patients who consume large amounts of fluids. Adverse effects. Water intoxication. It's a thing. Having way too much fluids. Signs and symptoms: drowsiness, lightheadedness, headache, coma, convulsions. Other adverse effects: tremor, sweating, vertigo, headache, abdominal cramps, flatulence, nausea, vomiting related to the stimulation of GI motility, local nasal irritation. Before I go to drug-drug interaction, just look at this box, 35.6, administering a nasal spray. You're going to teach a patient to sit upright, press a finger over one nostril to close it. You're going to teach them not to use excessive force and to not tip the head back, because these actions could result in ineffective administration. Make sure you guys read that entire box. Drug-drug interactions. There's an increased risk of antidiuretic effects if desmopressin is combined with carbamazepine or chlorpromide. Nursing considerations for patients receiving posterior pituitary hormones. You're going to assess them for any allergies. You're going to assess them for vascular disease, epilepsy, renal dysfunction, pregnancy, lactation. You're going to take the baseline of the patient as always. Monitor the patient fluids volume. You're going to watch for signs of water intoxication and fluid excess or excessive fluid loss. Monitor patients with vascular disease for any signs of exacerbation. Monitor condition of nasal passages if the medication is given intranasally. Key points. The posterior pituitary hormones are produced in the hypothalamus and stored in the posterior pituitary. And they only include two, your oxytocin and your antidiuretic hormone. These two are located in the posterior pituitary. Lack of antidiuretic hormone produces diabetes insipidus. Remember, antidiuretic hormones makes you hold on to all your fluids. If you don't have enough of that, you're going to let them all go and you're going to have diabetes insipidus. It's characterized by large amounts of what type of urine? Dilute urine and excessive thirst. Antidiuretic hormone replacement uses an analog of ADH, and that's your desmopressin. We don't ever give ADH itself for diabetes insipidus. Give desmopressin, and it can be administered parenterally or intranasally. Make sure you guys read that box on how to give it intranasally. Vasopressin blockers are used to restore sodium balance in patients with severe hyponatremia. Fluid balance needs to be monitored. Summary: growth hormone deficiency can cause dwarfism in children and SDS in adults. Growth hormone excess causes gigantism in patients whose epiphyseal plates have not closed, and acromegaly in patients with closed epiphyseal plates. That's our question. GH antagonist includes these two meds. I'm not going to try, of course I'm going to try to pronounce it. Octreotide and bromocriptine. Posterior pituitary hormones are produced in the hypothalamus and they're stored in the posterior pituitary. They include oxytocin and antidiuretic hormone. Those are the only two hormones we're going to find in that posterior pituitary. Worry about. Lack of antidiuretic hormone produces diabetes insipidus. and it's characterized by large amounts of dilute urine and excessive thirst. We've seen this a million times. Anti-diuretic hormone replacement uses desmopressin, an analog of ADH, and it can be administered enterally, parentally, or intranasally. Vasopressin blockers are used to restore sodium balance in patients with severe hyponatremia by preventing ADH from working, and greater amounts of urine being produced, leading to a concentration of serum. And lastly, fluid balance needs to be monitored when the patients are taking drugs that affect anti-diuretic hormone. So no excuses. Okay, guys. Hypothyroidism. Before I even get into this. So you guys know your thyroid glands is right here, right? Whenever you think of the thyroid gland, I want you to think of metabolism. Okay? So if a patient has hyperthyroidism, their metabolism is increased. They're burning calories. Everything is up. They're going. If they have hypothyroidism, their metabolism is decreased. They're burning less calories. Their blood pressure is lower. Their thinking has decreased. The GI tract peristalsis has gone down. Everything goes down. Okay? So we're going to start with hypothyroidism, where everything's up or down? Down. All right. Hypothyroidism. This is a lack of sufficient levels of thyroid hormones to maintain normal what? Metabolism. When you think of the thyroid gland, I want you to think of metabolism. This condition occurs in a number of pathophysiological states. Absence of thyroid gland. Well, yeah, if you don't have your thyroid gland, that's going to cause hypothyroidism. Lack of sufficient iodine. You need to know this. Lack of sufficient iodine in the diet to produce the needed levels of thyroid hormone. Lack of sufficient functioning of the thyroid tissue due to a tumor or autoimmune disease. Lack of thyroid stimulating hormone due to a pituitary disease. Lack of thyroid releasing hormone related to a tumor or disorder of the hypothalamus. Table 37.1, you guys need to know this. In hyperthyroidism, everything is up. The blood pressure, the pulse, the thinking, the you name it, the GI tract, right? In hypothyroidism, it's the opposite. So let's take a look. Hypothyroidism, CNS is going to be decreased. The cognition is going to be decreased. It's going to take them longer to think about something. They're going to be lethargy. They can be sleepy, slow speech, emotional dullness. Remember, everything's down. Cardiovascular system, again, depressed. That patient can have bradycardia, hypotension. Skin, hair, and nails. Skin's going to be pale. Why? Because of decreased blood flow. Remember, it's the oxygen, vitamins, nutrients, minerals that's carried in the blood that makes your skin nice and pink, that makes your hair look all beautiful and luscious and healthy, right? So the skin's going to be pale, coarse, dry, thick, puffy eyes and eyelids. Hair's going to be coarse and thin. Nails, thick and hard. The metabolic rate is going to be decreased. So this patient's going to have an intolerance to cold. Very important to know. Because remember, someone with hyperthyroidism, I think I did that in the room. I showed you what that kind of patient looked like. Kind of like the bipolar patient that's in the manic phase where they're all over the place. And hypothyroidism is kind of like the opposite, where everything is just slow. That patient that has hypothyroidism, everything has slowed down. They're going to have intolerance to cold. Decreased appetite. higher levels of fat and cholesterol, because remember, the metabolic rate is slow. They're not burning calories. Weight gain because they're not burning calories, right? Hypercholesterolemia, and something I added because it was not in the book, but NCLEX definitely expects you to know it, constipation. Even their GI tract slows down. The peristalsis slows down. Generalized myxedema, periorbital edema, thickened speech. We'll come back to hyperthyroidism after I cover hyper, but make sure you guys know this table and you know the difference of what a patient with hyper versus hypothyroidism looks like. We'll come back to this. Hypothyroidism is treated with replacement thyroid hormone therapy. They don't have it, we have to replace it. All right, let's talk about hyperthyroidism. Hyperthyroidism occurs when there are excessive amounts of thyroid hormones. These are produced and released into circulation. Graves' disease, which is a poorly understood condition thought to be an autoimmune problem, is the most common cause of hyperthyroidism. When you see Graves' disease, you need to think of hyperthyroidism. Goiter, that's enlargement of the thyroid gland. It's an effect of hyperthyroidism, which occurs when the thyroid is overstimulated by thyroid stimulating factor. And so you'll see their neck is much larger than it should be. You can see that goiter. Additional signs and symptoms of hyperthyroidism can be found in this table. I'll go over that in a second. Hyperthyroidism may be treated by surgical removal of the gland or portions of the gland, treatment with radiation to destroy parts or all of the gland, or drug treatment to block the production of thyroxine in the thyroid gland or to destroy parts or all of the gland. So they can get surgery, remove the whole thing. We may get drugs to suppress or stop that thyroid hormone from being produced. They can take a portion of it out. Where are my key points? Key points. The thyroid gland uses iodine. Iodine's important to know. It uses iodine to make the thyroid hormones. NCLEX expects you to know this. Hypothyroidism is treated with replacement therapy hormone, and hyperthyroidism is treated with thiamides or iodine. Before we get into thyroid agents, let's go back to that table and take a look at hyperthyroidism. Hyperthyroidism, CNS is stimulated. Patient can have insomnia, tremors, nervousness, restlessness, increased body rate. Everything's through the roof, even the temperature. So this type of patient, do you think they're going to have intolerance to cold or intolerance to heat? Heat, because their temperature is already increased, where the patient with hypothyroidism, their temperature is already decreased, so they're going to have intolerance to cold. Let's keep going. Hyperthyroidism, cardiovascular system, heart rate's going to be up. Patient can have palpitations, hypertension. The skin, flush, warm, moist. Make sure you guys know this table. You're going to see it again. All right, thyroid agents. When thyroid function is low, thyroid hormone needs to be replaced to ensure adequate metabolism and homeostasis in the body. When the thyroid function is too high, if the thyroid function is too high, is that hyperthyroidism or hypothyroidism? Hyper, very good. When the thyroid function is too high, the resulting systemic effects can be serious, and the thyroid will need to be removed or destroyed pharmacologically, and then the hormone normally produced by the gland will be replaced with thyroid hormone, and that is for the rest of their lives, or they will die. So think about it. If the patient has hyperthyroidism and it has to be removed, we remove that thyroid gland. Well, guess what? They need that thyroid gland to live. Remember, not they need the thyroid gland, they actually need the thyroid hormones. They need the thyroid hormones to live. Remember, those thyroid hormones, they're responsible for that patient's basic metabolic rate, right? So after it's been removed, they have to get replacement therapy for the rest of their lives. Thyroid agents include thyroid hormones and anti-thyroid drugs. And on the side, I wrote this for life. Don't forget that. So let's talk about the thyroid hormones. The thyroid hormones make everything go up. Blood pressure, heart rate, cognition, thinking, GI tract. Okay. Let's talk about thyroxine. That's a thyroid hormone that you need to know. That's our synthroid. It's a synthetic salt of the T4, and it's the most frequently used replacement hormone. So if a patient has to get a replacement hormone, this is the drug we expect to be given, thyroxine, okay? Actions and indications. Increase in the metabolic rate, the thyroid replacement hormones increase the metabolic rate of body tissues, increasing oxygen consumption, respiration, heart rate, growth and maturation, and the metabolism of fats, carbs, and protein. These drugs are not approved for weight loss, and they carry a warning that they're not to be used for weight loss. But you can understand why somebody would want to abuse them to make you lose weight, because remember, these hormones do what? Increases everything, including your metabolic rate, right? To make you burn calories, but there's no indication for it just for the person to lose weight. Contraindications and cautions. Allergy. Acute thyrotoxicosis, unless used in conjunction with anti-thyroid drug or during acute myocardial infarction, we're not going to be given these drugs. Just think about it for a second, guys. Levothyroxine is a drug that's going to increase your heart rate. It's going to increase your metabolism. It's going to increase your blood pressure. Everything goes up, right? Why in the world would you give this to a patient that is in acute thyrotoxicosis, that they're already up here through the roof? Or why would you give this drug to a patient during acute myocardial infarction, when we know what this can do to the heart, what it can do to the cardiovascular system? It only makes sense. Other contraindications and cautions: lactation, Addison's disease. Remember Addison's disease, where we need to add salt, add sex, add sugar, right? Addison's disease, because the body will not be able to deal with the effects of the drug. Next page. Adverse effects. When the correct dose of the replacement therapy is being used, few, if any, adverse effects are associated with these drugs. Some of the less predictable effects are associated with cardiac stimulation, arrhythmias, hypertension, CNS effects such as anxiety, sleeplessness, headache, difficulty swallowing, and esophageal atresia. Taking the drug with a full glass of water is strongly recommended to alleviate this effect. And I wrote down here that we often see this in the geriatric population. Yes, especially the cardiac, the cardiovascular, and the esophageal atresia. We see that more in the geriatric population. And NCLEX expects you to know that, because usually when they give you a question about these symptoms, they make it a geriatric patient. That's like one of the hints that they give you. Drug-drug interactions. Decreased absorption of thyroid hormones occurs if they're taking at the same time with cholecystramine. The effectiveness of oral anticoagulants is increased if they're combined with thyroid hormones. Because this can lead to increased bleeding, the dose of oral anticoagulants should be decreased. They should be reduced and bleeding time checked periodically. If that patient absolutely has to be on an oral anticoagulant while they're getting that thyroid hormone, you expect for the anticoagulant dose to be decreased. And you're going to be checking those bleeding times periodically. Decreased effectiveness of digitalis glycosides can occur when the drugs are combined. Consequently, digitalis levels should be monitored and increased dose may be required. Theophylline clearance. Theophylline clearance is decreased in hypothyroid states, which means more of that med stays in that patient's body. As the patient approaches normal function, the theophylline dose may need to be adjusted frequently. And in parentheses, I wrote decrease, so you can remember it. They're going to change it. You expect it to go down. You expect that dose to be decreased. Nursing considerations for patients receiving thyroid hormones. You're going to assess them for any allergy to thyroid hormone. Allergy to the thyroid hormone or binder, if they're breastfeeding, Addison's disease, acute myocardial infarction, thyrotoxicosis, all of those are contraindications. Implementation rationale. Administer a single dose, daily dose before breakfast each day. Ensure the drug's not expired before use. Why do you think we're giving it to them in the morning? Because it's stimulating everything. We don't want to give it to them at night, right? Are they going to sleep? No. And we want to, you made a good point. That's another reason. We want to basically fake the way that the body naturally releases this hormone, because remember, this is a replacement that we're giving to them. But naturally, your body releases the most what? In the morning, so you can have energy to go about your day. So here I wrote, what did I write here? Awake for days. Oh, awake for the days, sleep at night. Assess the patient carefully. You make sure you're also assessing their weight. You're going to check their weight to determine if the medication's been effective or not. Because if we're giving them this thyroid replacement, and we know thyroid replacement increases the metabolic rate, right? But that patient's gaining weight. They may have a subtherapeutic level. So one of the important things we have to do when we're assessing this patient is making sure that we're checking that weight. Lastly, we want to take periodic blood tests of the thyroid function. Anti-thyroid agents. The anti-thyroid agents do the opposite. They bring everything down. They bring down the heart rate. They bring down the blood pressure. They bring down the thinking, the cognition. They bring down the peristalsis. They bring everything down. The metabolic rate decreases. Everything goes down. All right? Drugs used to block the production of thyroid hormone and to treat hyperthyroidism include the thiamides and iodine solution. The thiamides and iodine solutions, those are your anti-thyroid agents. Those are the agents that bring everything down. Therapeutic actions and indications. Thiamides lower thyroid hormone levels by preventing the formation. Oh. Matthew, I'm teaching. What is it?
Monkey.
Yes.
What does shukka mean?
Who said that? Matthew, I'm teaching. I gotta go. Bye.
But what does it mean?
It's a movement of the hips. Goodbye.
What is
Matthew, I gotta go, something like that. Goodbye. It's a dance. Goodbye, Matthew. I'm gonna stop picking up your phone calls if you keep doing this. Anyone want a child? All right, guys, where was I? All right, so let's talk about the therapeutic actions and indications of the thiamides. The thiamides lower thyroid hormone levels by preventing the formation of thyroid hormone in the thyroid cells. They also partially stop the conversion of T4 to T3 at the cellular level. These drugs are indicated for the treatment of hyperthyroidism. The thiamides include your PTU and your tapazole. Make sure you know those two medications. Now let's talk about the iodine solution. Low doses of iodine are needed in the body for the formation of thyroid hormone. We know that. We just learned about that 2 pages ago. High doses, however, block thyroid function. So those low doses are needed for the formation of thyroid hormone, but having too much of it is going to block it. Therefore, iodine preparations are sometimes used to treat hyperthyroidism, but are not used as often as they once were in the clinical setting. The iodine solutions cause the thyroid cells to become oversaturated with iodine and stop producing the thyroid hormone. Radioactive iodine, that's your sodium iodine, that I-131 I told you have to recognize, because sometimes NCLEX will write it all out, or they'll just give you the symbol, that I-131. You have to recognize that as the radioactive iodine solution, okay? In some cases, the thyroid cells are actually destroyed. Excuse me, in some cases, the thyroid cells are actually destroyed. Radioactive iodine, sodium iodide I-131, is taken up into the thyroid cells, which are then destroyed by the beta radiation given off by the radioactive iodine. Except during radiation emergencies, the use of sodium iodide is reserved for those patients who are not candidates for surgery, women who cannot become pregnant, and elderly patients with such severe complicating conditions that immediate thyroid destruction is needed. So this kind of lets us know this is not our first option, right? On top, I wrote that when it comes to the radioactive iodine, it cannot be used around children. It can be used around pregnant women for a week after the treatment, because for a week after that person's been treated, they're still considered radioactive. So you have to teach them to stay away from pregnant women and children for a week. Pharmacotherapeutics. For the iodine solutions, the peak effect is seen 10-15 days. That's important for you to know. Sometimes the effects can take months. It takes time to kill the thyroid. It's not going to happen overnight. The peak effect can be seen 10-15 days, but sometimes the effect can take months. It takes time to kill that thyroid. Sodium iodine 131, it enters the breast milk and is rated pregnancy category X, as in never. Contraindications and cautions. We're going to assess them for any allergy to anti-thyroid drugs. We're going to assess them for pregnancy. If an anti-thyroid drug is absolutely essential, which means they're not a candidate for surgery, it's absolutely essential, and the mother has been informed about the risk of cretinism. Oh, hiccups, okay. Cretinism in the infant, PTU is a drug of choice. So if she's pregnant, PTU is a drug of choice, but caution should still be used. And you have to warn her that cretinism, that's like a learning difficulty. Another method of feeding the baby should be chosen if an anti-thyroid drug is needed during lactation, because it does enter the breast milk. Learning difficulty for the cretinism. Again, if an anti-thyroid drug is needed, PTU is a drug of choice for the pregnant mother. Adverse effects. Let's talk about the adverse effects of thiamides first. The adverse effects most commonly seen with thiamides are the effects of thyroid suppression, such as drowsiness, lethargy, bradycardia, nausea, skin rash. PTU is associated with nausea, vomiting, GI complaints, and severe liver toxicity. Let me stop right there. So those signs and symptoms of the thyroid suppression, such as the drowsiness, lethargy, bradycardia, nausea, skin rash, that's been seen on NCLEX very often as a select all that applies. Make sure you know it. And here where it says PTU is associated with nausea, vomiting, GI complaints, severe liver toxicity. Some things I did not see in this book, but NCLEX definitely expects you to know, so I wrote it on the side. Make sure you write it as well. God bless you. Agranulocytosis. Agranulocytosis, decreased WBCs, which means you're going to be watching out for signs and symptoms of what? Infection. Methimazole also associated with bone marrow suppression. And you know, whenever you see bone marrow suppression, you know the platelets are going to be decreased, you know the WBCs are going to be decreased, and you know the RBCs are going to be decreased. So you're going to be concerned about anemia, you're going to be concerned about bleeding, you're going to be concerned about infection. Yes.
So the decreased WBCs are part of that? Just the whole thing?
The PTU. Yeah. Now let's talk about the adverse effects of the iodine solutions. The most common adverse effect of iodine solution is hypothyroidism. As students, here's a big mistake you make when you guys get a question about a medication and they ask you, you know, what's going to be a priority nursing intervention. What test writers usually will do, they'll give you the patient's diagnosis and the medication, and then they're going to ask you what you're going to look out for. And as students, you get fooled and you want to choose an intervention for the diagnosis, but what they're asking you about is the medication. So what you need to be thinking about, priority, nursing priority for medication. What happens if this medication works too well? So if I'm giving insulin and insulin works too well, it could cause a hypoglycemic reaction. So my nursing priority is going to be looking for a hypoglycemic reaction. So when you're being asked about these medications, they're asking you about what happens if the medication is working a little bit too well. They're asking you about adverse effects of this medication, okay? So think about it. The most common adverse effect of an iodine solution is going to be hypothyroidism. Patient had hyperthyroidism. We're trying to decrease it. It works a little bit too well. Now we threw them on the other end of the spectrum. Hypothyroidism. The patient will need to be started on replacement therapy hormone to maintain homeostasis. Other adverse effects include iodism, which is a metallic taste and burning of the mouth. Sore teeth and gums, diarrhea, cold symptoms, and stomach upset, staining of the teeth, skin, rash, and development of goiter. Now for the, excuse me, the adverse effects of iodism, iodine, you see where it says iodism, the metallic taste and burning of the mouth? Make sure you know it. I've seen NCLEX ask about, you know, the adverse effects of iodine solution a lot, and they'll give different types of questions, but this iodism shows up over and over and over. That's just one of those things when it comes to iodine solutions they really want you to know. And remember, if for whatever reason a patient is thrown into hypothyroidism, they will need replacement for the rest of their lives. It's not something they can just take for a couple weeks and then they stop taking it. They will die. Drug-drug interactions for thiamides. Oh, I'm not done with iodine solution. Let's go back. Adverse effects for iodine solutions. Radioactive iodine is usually reserved for use in patients who are older than 30 years of age because of adverse effects associated with radioactivity. Now we can do drug-drug interactions. For thiamides, an increased risk of bleeding exists when PTU is administered with oral anticoagulants. For methimazole, remember we're giving it to treat hyperthyroidism. Don't forget those adverse effects you need to know about: the skin pigmentation, bone marrow suppression, epigastric distress. For the strong iodine products, make sure that those are given for the hyperthyroidism. Make sure you know those adverse effects. Let's go over the nursing considerations for patients receiving anti-thyroid agents. You're going to assess them for history of allergy to any anti-thyroid drug, pregnancy, lactation, liver dysfunction, pulmonary edema, pulmonary tuberculosis if they're using strong iodine solutions. You're going to assess for skin lesions, orientation, affect, blood pressure, pulse. You're going to take their vitals. You need a baseline. For implementation rationale, you're going to administer the PTU 3 times a day around the clock. You're going to give iodine solution through a straw. Why? Because it can stain the teeth. Well, it does stain the teeth. You're going to monitor patients receiving iodine solution for any signs of iodism so that the drug can be stopped immediately. You see those signs of iodism, you are not going to give that medication. You're going to withhold it and contact the healthcare provider immediately. Key points. Hypothyroidism, or lower than normal levels of thyroid hormone, is treated with replacement thyroid hormone. Hyperthyroidism, or higher than normal levels of thyroid hormone, is treated with thiamides, which block the thyroid from producing thyroid hormone, or with iodines, which prevent thyroid hormone production, or it destroys part of that thyroid gland. Page 621, this parathyroid gland, you guys read that on your own. Let's jump to the next page. Now, something I'll say to you that you should already know. Hold on a second, guys. Just like when we're talking about the thyroid gland, I told you to think about metabolism. When you're thinking about the parathyroid gland, I want you to think about calcium. All right? So if the parathyroid gland is overactive, the calcium in the blood is going to be high. You're going to have hypercalcemia. If the parathyroid gland, if the functions decrease, the calcium in the blood is going to be low. Okay, so just like when you think about thyroid, you're thinking about metabolism. When you think about parathyroid, I want you to think about calcium. But let's be specific. Calcium where? In the blood, because as students, you guys mess it up and you think in the bone, and that's what screws you over on these test questions. In the blood. Hypercalcemia or hypocalcemia. Okay. So parathyroid dysfunction and related disorders. Parathyroid dysfunction involves either absence of PTH That's hypoparathyroidism or overproduction of PTH, hyperparathyroidism. So let's start with hypoparathyroidism, which means the patient's going to have decreased calcium in the blood. The absence of parathyroid hormone results in low calcium level, hypocalcemia, and a relatively rare condition called hypoparathyroidism. This is most likely to occur with the accidental removal of the parathyroid gland during thyroid surgery. Treatment consists of calcium and vitamin D therapy to increase calcium levels. So the patient could have had hyperthyroidism, right? And now they're getting surgery to remove that thyroid or a portion of the thyroid. But if you go back and recall your A&P, those parathyroid glands, those 4 nodules, sit right there on the back of that thyroid gland. So while the patient was getting part of that thyroid gland removed, it's very likely that the parathyroid gland could have been affected. So if you get a test question that they're talking about thyroid surgery, you still need to consider the parathyroids because of the location, okay? Now let's talk about hyperparathyroidism. With hyperparathyroidism, you're going to have increased calcium in the blood. The excessive production of parathyroid hormone leads to an, I'm sorry? Sorry. The excessive production of parathyroid hormone leads to an elevated level of calcium level, hypercalcemia, and a condition called hyperparathyroidism. The patient presents with signs of high calcium levels. The genetically linked disorder, Paget's disease, is a condition of overactive osteoclast. What is osteoclast? Remember, osteoblast is to build up and osteoclast is to break down. So look at this. The genetically linked disorder, Paget's disease, is a condition of overactive osteoclasts where the bone keeps breaking down that are eventually replaced by enlarged and softened bony structures. Patients with this disease complain of deep bone pain, headaches, hearing loss, and usually have cardiac failure and bone malformation. Estrogen normally causes calcium deposits in bone. Osteoporosis is one of the many complications that accompany the loss of estrogen at menopause. Let's talk about this for a second. I think I talked to you briefly about this last week, where estrogen is one of those things that actually keeps the calcium in the bone. But once a woman goes through menopause, estrogens decrease, calcium leaves the bone and goes into the blood. All right, let's go over key points. Parathyroid gland produces parathyroid hormones, which together with calcitonin, this is important to know, guys, maintains the body's calcium balance. A low calcium level, that's hypocalcemia, that's treated with a vitamin D and calcium replacement therapy. Hypercalcemia and hypercalcemic states are associated with postmenopausal osteoporosis, Paget's disease, and renal failure and malignancy. Parathyroid agents. The drugs used to treat disorders associated with parathyroid functions are drugs that affect the serum calcium levels. Notice we keep talking about the blood. Nobody's mentioning the bones here. So when we're talking about these calcium levels, it's in the blood. There are 2 parathyroid replacement hormones available and 1 form of calcitonin. Other drugs affect calcium levels in different ways. Anti-hypocalcemic agents. Deficient levels of parathyroid hormone results in hypocalcemia. So if you don't have enough of the parathyroid hormone level, your calcium in the blood is going to be low. Vitamin D stimulates calcium absorption from the intestine and restores the serum calcium to a normal level. So that vitamin D is important for the absorption of the calcium. Hypoparathyroidism is treated primarily with vitamin D and, if necessary, dietary supplements of calcium. However, there are two PTH forms available for therapeutic use. Your Forteo, a PTH genetically engineered from E. coli bacteria using recombinant DNA technology, and parathyroid hormone Natpara. Take a look at this box, box 37.5, gender considerations. So when it comes to osteoporosis, besides the use of biophosphates to encourage calcium deposition in the bone, several other interventions can help severe osteoporosis in this group or in any other people with similar risk factors. So someone has osteoporosis. Now we're talking about decreased calcium, not in the blood, but decreased calcium in the bone, right? So they're talking about, besides biophosphates are drugs that we can give to help strengthen the bone, to bring that calcium back into the bone. What else? Aerobic exercise. You teach that patient that, walking, even just for 10 minutes a day, can help increase osteoclast activity. Proper diet, eat foods high in calcium, vitamin D, protein, lose weight. Hormone replacement therapy. For women, hormone replacement therapy has been successful in decreasing the progression of osteoporosis. However, results of women's studies showed an increase in cardiovascular events such as strokes, clots, and dementia with long-term hormone replacement therapy. The use of hormone replacement therapy has been linked to increased risk of breast cancer. Let me stop right there because I got to make sure this is clear to you guys. It does not give you breast cancer, but you have breast cancer in your body and you didn't know, but it's there. It feeds that cancer, so that cancer grows, okay? It doesn't cause cancer, but it feeds the cancer to grow if you do have it. The use of biophosphates may be a better choice of drug therapy for many patients. Yes.
I would like to go over the detail of table 37.
Oh, thank you. Let's go to table 37.3. You absolutely need to know this. You need to know the difference between hyper and hypocalcemia. All of those signs and symptoms you guys learned in Foundations of Nursing, you need to bring it back to your recall, right? Remember when you guys were learning about fluids and electrolytes? So hypocalcemia, hyperactive reflex, Trousseau. Trousseau starts with a C, so does your cheek. That's the one where you touch your cheek and they go like this, right? That's the hyperactive reflex. Trousseau is the one where you take their blood pressure and then as a cuff squeeze, you see their head, it's tetany, you see their hand going like this, okay? Those are signs and symptoms of hypocalcemia, the hyperactive reflexes. Hypotension, prolonged QT interval. Tetany, skeletal muscle cramps, carpal pedal spasms, laryngeal spasm, tetany. And on the side, I put select all that apply on NCLEX. Make sure you know them. Bone pain, osteomalacia, fractures. Now for hypercalcemia, lethargy, stupor, coma, hypertension, anorexia, constipation, muscle weakness, ataxia, kidney stones, because all those calcium and just clumps up together in the blood and now the patient's got stones. Renal insufficiency, osteopenia, osteoporosis. make sure you know the difference of hyper versus hypocalcemia. Yes.
For the medication, the biophosphate, if you have breast cancer that runs in your face, you can give somebody that medication. Who says that they're at risk for breast cancer?
Not for the biophosphates, for the hormone replacement therapy.
Yeah, that.
No, they would not give hormone therapy. Okay, so we're back to the hypocalcemic agents. An additional hypocalcemic agent is calcitriol, which is the most commonly used form of vitamin D. Tymlos is a medication approved for treatment of women with high risk of fracture due to osteoporosis. Table 37.4, I put a star next to the most important drugs you need to know as far as the hypocalcemic agents, your biophosphonates, your calcitonin. Can you guys see this clearly? Your calcitriol, your parathyroid hormone, your alendronate, that's your Fosamax. Ibendronate, your calcitonin. All right, therapeutic actions and consideration and indications. Vitamin D compounds regulate the absorption of calcium and phosphate from the small intestine, mineral resorption in bone, and reabsorption of phosphate from renal tubules. The key word in all of this when it comes to vitamin D is absorption. Okay? Excuse me. With once daily administration, teriparatide stimulates new bone formation, leading to increase in skeletal mass. Parathyroid hormone acts as a replacement for missing parathyroid hormone. This drug, I'm not going to try to pronounce it, acts to increase bone mineral content to strengthen bone. Use of these agents is indicated for the management of hypocalcemia patients undergoing chronic renal dialysis and for the treatment of hypoparathyroidism. Because remember, with hypoparathyroidism is hypocalcemia. Teriparatide is also used for the treatment of postmenopausal or hypogonadal osteoporosis and osteoporosis associated with sustained systemic glucocorticoid therapy. Let's stop right there for a second. Remember, when it comes to those steroids, those glucocorticoids, right? Yes, they suppress those signs and symptoms of infection. Yes, they're hard on the stomach and they can cause ulcers, but they can also cause fractures. Remember, they can cause osteoporosis. So that's something important to remember. Parathyroid hormone is only approved for maintenance of calcium levels in patients with hypoparathyroidism. Contraindications and cautions. Allergy or component to the drug. Hypercalcemia or vitamin D toxicity. That makes sense. If the patient already has too much calcium in the blood or they got too much vitamin D, why would we give this to them? If they have if they're pregnant, they have a history of renal stones, or if they're breastfeeding. Abaloparatide and teriparatide and parathyroid hormone are associated with osteosarcoma, a bone cancer in animal studies, so its use is limited to postmenopausal women who have osteoporosis, are at high risk for fractures, and are intolerant to standard therapies, and to men with primary or hypogonadal osteoporosis or patients on sustained systemic glucocorticoid therapy who are at high risk for fracture and they're intolerant to standard therapy. These patients should also take supplemental calcium and vitamin D, increase weight-bearing exercise, and decrease the risk factors such as smoking and alcohol consumption. And that list is often a select all that applies as well, which you're going to teach the patient. Weight-bearing exercising, decreased risk factors such as smoking, excessive alcohol consumption. Make sure that they're taking their calcium, but also their vitamin D for absorption. Adverse effects. Make sure you guys take a look at those effects, the GI effects, the CNS effects. Severe hypocalcemia and hypercalcemia have occurred with the use of parathyroid hormone. Drug-drug interactions. The risk of hypermagnesemia increase if the drugs are taken with magnesium-containing antacids. So make sure that they are avoided. You're going to teach the patient to avoid them when they're on these drugs. Digoxin toxicity can occur with hypercalcemia. Nursing considerations for the patient taking anti-hypocalcemic agents. You're going to assess them for any allergy to any component of the drugs. Hypercalcemia, vitamin toxicity, renal stones, pregnancy, lactation. You're going to assess them for the presence of any skin lesions. You're going to check their serum calcium levels before giving it to them, their magnesium levels, alkaline phosphate levels. Implementation rationale. Monitor serum calcium concentration before and periodically during treatment. Provide supportive measures. Arrange for a nutritional consultation if GI effects are severe. Provide thorough patient teaching. Anti-hypercalcemic agents. Are you guys good or you need a little break? Okay, good. Even better. All right, anti-hypercalcemic agents. Drugs used to treat parathyroid hormone excess. So now we have too much. Excess or hypercalcemia include the bisphosphonates and calcitonin salmon. These drugs act on serum levels of calcium and do not suppress the parathyroid gland or PTH. Therapeutic actions and indications of the calcitonin or the bisphosphates. The bisphosphates act to slow or block bone resorption. Let's stop there. Remember, I taught you about that one letter that makes a big difference in your test question. You have bone reabsorption to take back up and resorption to let go. Read very carefully. The bisphosphates act to slow or block bone resorption. By doing this, they help to lower serum calcium levels, but they do not stop the normal bone formation and mineralization. And then they give you the list of bisphosphonates. Make sure you know these drugs. These drugs are used in the treatment of Paget's disease and of postmenopausal osteoporosis in women. And alendronate is used to treat osteoporosis in men. Because remember, estrogen is to women what testosterone is to men. And so as a man gets older and his testosterone level decreases, that can put him at risk for osteoporosis, just not at as high a degree as it does to a woman. So zoledronic acid is also used to prevent new fractures in patients with low trauma, hip fractures, and to help patients with multiple myeloma or documented bone metastasis from solid tumors. Calcitonins. The calcitonins are hormones secreted by the thyroid gland to balance the effects of parathyroid hormone. Currently, the only calcitonin readily available is calcitonin salmon. It inhibits bone resorption. Notice it says inhibits bone resorption, not inhibits bone reabsorption. Hint, hint. Inhibits bone resorption, lowers serum calcium levels in children and patients with Paget's disease, and increases the excretion of phosphate, calcium, and sodium from the kidneys. Pharmacokinetics. As far as biphosphonates, these drugs are well absorbed from the small intestine and do not undergo metabolism. For calcitonin, calcitonin salmon can be given by injection or by nasal spray. Contraindications and cautions. Biophosphonates should not be used in the presence of hypocalcemia, which could be made worse by lowering the serum calcium levels. We're going to assess the patient for allergy to biophosphonates. Another contraindication is if the woman's breastfeeding. Alendronate should not be used by nursing mothers. Renal dysfunction, upper GI disease. Those are other contraindications. This has been seen on NCLEX, so make sure you know this. Alendronate, ibendronate, risendronate need to be taken on arising in the morning. Guys, if it says on arising, did it say after eating breakfast? On arising in the morning with a full glass of water 30 minutes before any food or beverage, and the patient must remain upright for at least 30 minutes. They are very, 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 very hard on the esophagus. So the reason you need to sit up is because if that medication creeps up through that cardiac sphincter and goes through the esophagus, it will cause a horribly burning sensation. Okay, so the patient has to take it in the morning before they have anything to eat or drink. They're going to take it with a full glass of water, and they absolutely must sit up for at least 30 minutes after taking that medication. No lying down. You have to teach that to the patient. These drugs should not be given to anyone who's unable to remain upright for 30 minutes after taking the drug. Zoledronic acid should be used cautiously in aspirin-sensitive asthmatic patients. It may be given as an intravenous infusion once every 2 years for osteoporosis. Ibendronate is available as a once-a-month formulation and an IV preparation. Talk about the calcitonin. This drug should be used in pregnancy only if the benefits outweigh the potential risk to the fetus, and it should not be used during lactation. Calcitonin salmon should not be used with known allergy to salmon or fish products. This drug should be used with caution in patients with renal dysfunction or pernicious anemia. Adverse effects of the biophosphonates. The most common adverse effects seen with biphosphonates are headaches, nausea, diarrhea. There's also an increased risk in bone pain in patients with Paget's disease, but this effect usually passes after a few days to a few weeks. So you have to let them know that. You have to let them know they may feel this, but it should go away or diminish greatly after a few weeks. Esophageal erosion has been associated with alendronate, ibendronate, and risendronate if the patient has not remained upright for at least 30 minutes after taking the tablets. Long-term use of biphosphonates over 5 years has been associated with increased risk of femoral shaft fractures. Current guideline is to limit the use to a 3 to 5 year max in patients at low risk for fractures. Calcitonins. The most common adverse effects seen with calcitonins are flushing of the face and hands, skin, rash, nausea and vomiting, urinary frequency, local inflammation at the site of injection. Drug-drug interactions. Oral absorption of biphosphonate is decreased if they're taken at the same time with antacids, calcium products, iron, or multiple vitamins. If these drugs need to be taken, they should be separated from the biphosphonates by at least how long, guys? 30 minutes. Here, guys, I just highlighted the medication. I didn't underline or put a star next to anything. Nursing considerations for patients receiving anti-hypercalcemic agents. We're going to assess them for any allergies to the products, to fish products with calcitonin salmon, pregnancy, lactation, renal dysfunction. We're going to get a baseline on our patient. Implementation rationale. We're going to ensure adequate hydration with any of these agents. Arrange for concomitant vitamin D, calcium supplements, and hormone replacement therapy. Rotate injection sites and monitor for inflammation if using calcitonins. Monitor serum calcium regularly. Assess the patient carefully for any drug-drug interactions. Arrange for periodic blood tests of renal function if using gallium. Key points. Parathyroid glands are located behind the thyroid gland to produce parathyroid hormone, and it works with calcitonin produced by the thyroid cells to maintain the calcium balance in the body. Hypocalcemia, or low levels of calcium in the blood, is treated with vitamin D products and calcium replacement therapy. Hypercalcemia, or high calcium in the blood, can occur in postmenopausal osteoporosis and Paget's disease, as well as hypercalcemia related to malignancy. Hypercalcemia is treated with biphosphonates which slow or block bone resorption. Summary. The thyroid gland uses iodine to produce thyroid hormone. Thyroid hormones control the rate at which the body cells use energy, metabolism. When you think of the thyroid gland, I want you to think of metabolism. Hypothyroidism, or lower than normal level of thyroid hormone, is treated with replacement thyroid hormone. Hyperthyroidism, or higher than normal levels of thyroid hormone, is treated with thiamides or with iodines. The parathyroid glands work with calcitonin produced by the thyroid gland to maintain the calcium balance in the body. Hypocalcemia, or low levels of calcium in the blood, is treated with vitamin D products and calcium replacement therapy. Hypercalcemia and hypercalcemic states include postmenopausal osteoporosis and Paget's disease, as well as hypercalcemia related to malignancy. Let's talk about this just for 1 second, because I don't want you guys to get confused. Think about it. Look what it's saying. It's saying hypercalcemia and hypercalcemic state is associated with postmenopausal osteoporosis and Paget's. Why? Because hypercalcemia is high calcium where? In the blood, not in the bone. Hypercalcemia is treated with biphosphonates or calcitonin. Biphosphonates slow or block bone resorption. I'm sorry? Oh, okay. Calcitonin inhibits bone resorption, lowers serum calcium levels in children patients with Paget's disease, and increases the excretion of phosphate, calcium, and sodium from the kidney.